Most of our cases here that we are facing, we are treating it in conservative management, like stenting, clipping, CT drainage, and it works mostly with most of the patients. We looked at the pharmacological treatment, and we thought there must be or we thought that there is a common organisms with the post-leak infection. So we looked for all the cases we treated here to have a pattern of infection or a map of common organism in these patients, so we can target the infection with the proper antibiotics. So we studied the patients from 2011 to 2015 in King Khalid University Hospital who had leak post-sleeve gastrectomy. Some of them our cases, and others referred from other centers. We include only the patients with documented leak by CT scan and who didn't start any treatment outside our center. And we excluded the patient who had no culture or no drainage of the collection. We end up with 42 patients, 11 excluded, so 31 were included. The mean age were 31-year-old, average BMI 48. 14 patients were female, and 16 were female, and 14 were male. The mean time of presentation was 12 days post-operative, presenting symptoms including shortness of breath, palpitation, tachycardia, tachypnea, and fever. All patients received the fluid resuscitation and empirical antibiotics in ER, and CT done for them with one cup of table of contrast on table. Drainage was done to all 31 patients with CT-guided intervention radiology on average of day 13 post-operative. That means the next day of admission. Drain kept in place and sample from collection sent for culture. Average time of drainage removal was 75 days post-operative. The site of collection was left subdiaphragmatic in all patients. One patient had additional collection in the subhepatic and pelvic area. 10 patients had left pleural effusion that required drainage to improve the respiratory function. Endoscopy was done to all patients and stent placed over the leak. Site of leak was found at the gastroesophageal area in 30 patients. One patient had a lower stapler leak. So we studied the organism. Positive culture result from 28 patients. That means 90% of patients had positive result. 3 patients had negative culture results, which account for 9.6%. Interestingly, the Candida species were isolated from 19 patients, which is around 61.2%, and bacteria isolated from 18 patients, less than the Candida with a percentage of 58%. Mixed Candida and bacteria were isolated in 9 patients, which counter 29% of patients. So the Candida infection were commonly encountered in these patients, and it is less treated by most of us. That we start usually on broad spectrum antibiotics, and we wait for cultures. When we get the result of the Candida, then we start our treatment. So with these results, I think there were 10 out of the 19 patients who had positive Candida showed only Candida isolation. There was no bacteria. And that means 32% had only Candida infection. The Candida albicans was isolated from 13 patients, which is 68%. Only bacteria with no Candida were found in 9 patients, which is around 29%. Most of the bacterial culture showed single organism, with 7 patients had 2 organisms and 4 had 3 organisms. Klebsiella was the most common, followed by Streptococcus and Pseudomonas species. This is a table that shows the number and the different kind of organism. As we said, the Klebsiella was the most common, followed by Streptococcus and Pseudomonas. In the bacterial group, and the Candida albicans was the most common one. This is just another diagram showing the same result. So there was reports about the risk of yeast intraperitoneal infection. And they found that one of the risk factors for isolation of yeast is an upper GI leak. Upper GI leak means duodenal perforation and whatever is that above the ligaments of trides. There is an old study that suggested that low dose amphotericin B will cause less mortality in these patients. So we should be serious with these kind of patients and try to optimize whether the treatment of antifungal is effective or not. I think we should consider it in this kind of patients. We don't know that they will go for a severe infection. So we have to hit the organism as early as we can, with covering the most common ones at least, to be in the protective side. So we should consider the antifungal treatment in the. We suggest that we consider the antifungal treatment in the first line of treatment in these patients, along with the broad spectrum antibiotics. And thank you.
Thank you very much, Dr. Saad. This is certainly a very interesting paper that challenges our understanding for the flora of upper GI and the pattern of infection. I would like to ask you for the study design. Have you segregated patients who had antibiotic therapy in another institute before they come in here? Meaning, is this fungal infection a reflection of the leak or a reflection of the broad-spectrum antibiotic therapy that patient had before landing in KQH?
Yes. As I mentioned in the exclusion criteria, that patients who received antibiotic treatment or antibiotic treatment excluded from the study. So we just give them one dose of antibiotics on ER. This may cause the fungal infection. We're not sure, but it's just one dose the day before the drainage. And we don't know how the significant it will be that dose.
And patients treated with antibiotic in other hospitals are excluded?
Excluded, yes.
Wonderful. You get a question there.
So in empirical therapy with antibiotic, you want to give fluconazole or amphotericin as a straight?
No, fluconazole.
Fluconazole.
The amphotericin is just an old study that suggests that
and
the treatment.
What you mean about some low dose amphotericin? What is the dose?
Yeah, that one is an old study, but it was the only one that suggests that it could be, it could lessen the mortality. I'm not sure how this could apply here, but I just mentioned it to show the importance of it. We usually use fluconazole or mostly fluconazole, yes. Yeah.
Dr. Isam.
Thank you, Dr. Saad, for your presentation. It's highlight the issue of fungal infection and yeast in such patient with post-leak. We just recently published in the medical mycology case report one patient who did sleeve gastrectomy outside the kingdom, and it was found to be a very rare case of yeast called Baetica cadresvae, something that's really very rare thing, and it was being accepted for publication. So just to give an attention to all our colleagues regarding fungal infection can be, and even the yeast.
Thank you very much.
Thank you. Yes, Professor.
That's the macro for such cases, and this is a fungal.
Thank you very much. Yes.